So this index case presented to us with a history of walking difficulty with frequent fall and also having the complaints of the urinary incontinence in the form of continuous dribbling as well as having the persistent constipation. On examination, the child was having the finding in the form of bilateral pes cavus as well as the atrophy of muscle involving the foot and absent ankle reflexes. Sensation were also affected. Patient had the atonic type of bladder with overflow incontinence and continuous dribbling of the urine. There was also fecal impaction and fecal masses were palpable on per abdominal examination. So we thought the possibility of some myelopathy and especially the involvement of tethered cord. For that, we examined the spine and spine was clear. There was no overlying defect on the spinal area. Neither sinus or any abnormal discoloration or tuft of hair were visualized. So we performed MRI of spine of this child. The MRI spine of the index child, while describing this MRI, you will say that this is MRI spine, sagittal view, T1 weighted image, and the important finding here is localized to the cord. If you clearly see these images, then in this section you can visualize the cord the best. The best cord is visualized in this section. So very important finding, pertinent finding here is that normally you know that in pediatric age group and also in adults, the maximum cord can extend up to the L1 and L2 level. Cords even in the neonate or infant do not extend below the L2 level. So here if you see the cord, this is the cord that is extending up to the sacral area, lower lumbar and sacral area. Okay, so this card is low lying card. And the second important finding is you all know very well that fat in T1 weighted MRI appears bright. So any fat that is bright seen will be seen bright on T1, like this area, like this posterior part of skin containing the fat, like this prevertebral areas. So these are basically the fat areas, so they will appear bright. Similarly, a similar finding is seen here. So this lower part of card is attached via fat to the skin. So this part is very important. This part is very important. This is basically the fat. The white color fat is seen here. That is attaching this card to the spine. So the important finding here is that this is basically a case of tethered card syndrome. So card is low lying. Card is extending up to the sacral vertebra and via a white material that is fat, that is lipomatous material, it is attached to the spine. So this is basically a case of tethered cord syndrome. As the cord is attached, tethered and pulled, so the function of cord will be disturbed. So there will be the myelopathy. So our patient index patient had symptom in the form of fecal impaction and constipation, as well as the urinary incontinence in the form of continuous dribbling, and as well as the finding in the foot in the form of pes cavus and also the atrophy. So this is case of tethered cord syndrome. In this case, we will proceed for the surgery and we will release the point of tethering, that is attachment. So in this case, the symptom will improve in this child. Thank you.